We'll throw it open to questions. Once again, please, if you could just briefly introduce yourself and what organization you belong to. And if your question is either directed at Principal Secretary Health or at Professor Muralidharan, or if it is open to anybody, that would be great. There are two mics right here. Any questions about the evaluation, any problems that they had in the district, how the government and JPAL work together, anything goes. Rachel.
I wonder if I've watched some other deworming programs in other places, and sometimes there has been, if children have a lot of worms and they take a pill and they feel a little sick, and there's sometimes been community reaction, a negative community reaction. And I wondered if you could talk about how you raise public awareness of the program to make sure that you didn't have a negative reaction if any child felt sick as a result of taking.
Yeah, that's right. I mean, very often when you pick up these kind of drives, any child suddenly does stool or vomit or have any loose motions, immediately there's commotion. And we did have one instance of that in Prakasham district. But that's quite natural. We handled it through the I.A.S. In fact, we had a chance to get a lot of good I.A.S. material prepared. The tableau which I shown the last slide was also an effort in raising awareness on deworming and how that a simple program like this can really bring tremendous results. So this I.A.S. material was actually handed over, and then in the committee we had training programs also drafted at the district level, where we have the district education officer and all the mandals. Our basic unit of administration in Andhra Pradesh is called a mandal, the revenue mandal, which is let's say about 10 to 15 villages. So each mandal we have a mandal education officer. So mandal education officer, the school headmasters or headmistresses, all of them were actually imparted a training program. One day training at the district headquarters, another day training at the, that is the trainers were trained at the state level, and the second level of training at the district level, and actual training at the mandal level, where we raised all these issues. And to enable in addressing in time such problems, the health officials would be also available in each school. So we detailed the ASHA workers as well as the ANMs and the medical officers, so that any such complaint they would immediately go there, and it was not a major problem. But yes, I agree with you that whenever we are administering pills, there is always a problem, and we also insisted that everyone must not take it on empty stomach. So that was another kind of thing which we took care of. And we also saw to it that there was clean potable water available in all the schools. So to that extent, we also distributed the chlorine tablets so that there is no contaminated water anywhere which was drunk by the children. Thank you.
My name is Shashi Bhushan, and I'm from Gandhi Foundation, Hyderabad. One small question about the program. The overall impact of intervention is the impact of children's, the lessening of absenteeism. But for a child, there could be innumerable reasons, say 10, 20, or his reason to be absent in the school. That could be the one, and deworming could still be part of that. So, what they refer to isolation, particularly because of this intervention, the absenteeism was lesser. I'm asking the question of isolating the impact of this particular intervention.
I'm glad you asked that question, because it gives, like Rachel did, to repeat exactly what the beauty of the randomized evaluation is. See, it's precisely the fact that all these other factors, see, in the randomized evaluation between the treatment group and the control group, the only thing that is different between those two groups is that the treatment group got the deworming pill. So that decrease in absenteeism is not relative to before and after, but relative to the control group. And because all these other factors on average have to be the same in the treatment and the control group, any difference that you see can statistically be attributed to the deworming program. Does that answer the question?
My question is generally, overall we are talking about the policy intervention. Now that the previous speakers also, we heard about that interventions for making the ANMs sensitive to their duties, whether through the incentive or disincentive. Similarly now about, but all these are public health issues, and all these are issues which requires a lot of involvement of community at times. Somehow in the policy level, I don't know, there is any scope of involving the people at last. They are the stakeholders, they are the main stakeholders. So is there any policy of involving the stakeholders? See, and is it through the local governance who has a major role to play, especially after the 73rd Amendment? Panchayats, they have been mandated with many of the issues at that level. So are there any policy interventions which suggest that they could be involved, or it has been studied and it has been found that it's not really effective way of delivering things? Because that's one area we are completely, I don't know, either ignoring it, or we have not explored it. I don't know what it is, I mean, because that has not figured out. So I would like to know as to what's because accountability is another issue, which is the major issue. And accountability could be ensured by the involvement of the local governance and also by these stakeholders, that is the people directly, through the Gram Sabhas. That's the most, in fact, talking of the ANMs, it has been also found that wherever the Gram Sabhas, the states where the Gram Sabhas are very strong, it has been found that presence of government officials, whether ANM or the teachers in the schools, it has been found that the attendance is better, the absenteeism is less, and is much more productive. That's how it has been found. That is just one. So what has been your experience in the whole? Thank you.
Thank you. I'll let Karthik respond in detail, but I will mention that the 4:15 p.m. session that we have on education with Pratham is actually going to touch upon how do you involve the community, and that was actually the experiment in West Champaran in Bihar itself, where a lot of volunteers have been involved in the Read India project. So that's absolutely coming down the schedule, but in the meantime I'll request Karthik to give you some more examples if possible.
Yeah, so that's exactly what I was going to talk about. So in the afternoon session, there are other professors here who are experts specifically on governance, And so, as we know, education and any of these social problems are very, very multifaceted issues. So there are, in education, there are inputs from the parents, there's inputs from the schools, from the teachers, from the community. And so what the randomized evaluations are trying to do is to isolate these channels one by one in a series of studies, and says that if you have limited bandwidth, whether you have limited financial capacity, limited managerial capacity, so should you be spending your time trying to activate the community, or should you be trying to spend your time coming up with a better program? Should you be spending your time trying to come up with alternative delivery models? So there are many, many things that compete for limited resources of money and attention. So in fact, that's exactly what we're trying to do, is to say, let us look at the impact of governance interventions, that Rohini will talk about later today. Let us look at the impact of specific programmatic interventions like deworming. Let us look at, so in education, for example, an interesting example is the use of the para-teacher. So the para-teacher is an interesting example that is both a program, but it also involves the community, because the contract is renewed at the level of the village as opposed to renewed at the higher level. So we have studies that show, for example, that the contract teachers, so in Andhra Pradesh, that was one of the interventions we did, that the contract teachers have much lower levels of absenteeism. So the regular teacher absence is about 25 to 27%, while the contract teacher absence is about 15-16%. Now, there could be many reasons for this, one of which is that if it's annually renewable contract, the incentives for performance are higher. But the other reason could be that community was involved. So in fact, Professor Duflo, as part of another study in Kenya, in fact looked at different aspects of contract teachers and tried to see what happens when you strengthen the school management committee. So that is a way of strengthening the community in terms of oversight of the local public good institutions. And they did find that that had a positive effect. But again, given that you have limited resources, it's not enough to know did it have a positive effect. You have to compare with all the other things you've repeated.
Hello, yeah, I'm Dr. Sharan Murthy from USL, and thank you for the great, wonderful presentations. I just have two comments. One even pertaining to the earlier presentation. In Bihar, we have achieved considerable progress. The government has achieved considerable progress in routine immunization, from 11% to 50%. And through this journey, they tried various things. Beneficiary incentive, beneficiary disincentive, provider incentive, provider disincentive. Yeah. And finally, what was found to be working is provider incentive. And there's a very interesting, you're invited to have a look at the current model for routine immunization in Bihar under a project called, program called Muskan, where there are performance-based incentives, as you were mentioning in the previous presentation of giving more if you do more. So that's exactly the principle behind this. And we've seen that it is working reasonably well. So just wanted to brief the audience on that. Two is, a good part of that program is also ensuring predictability of the session. Because predicting the availability of service is very important, and that is again something which the program has done. But what I would like to say is, in our experience in preventive interventions, supply is far easier than demand. Slightly contrary to what was said on the last slide, that supply is very hard. In our experience, we found that ensuring supply is still more easier than really ensuring demand. So that is my experience. The other issue on deworming is just to inform that there is a school health program running here, and deworming is a part of it. But UNICEF and the government of Bihar is planning to do a worm load estimation in the first quarter in all three categories, that is school children, pregnant women and adolescents. And there is statewide prevalence estimates which will be derived from that. But again, what I would like to ask is, data shows that better health impacts, of deworming. I mean, as due to deworming, children who are suffering from worm infestation is much more in the preschool age group. So did Andhra Pradesh actually have something for preschool children and the lower age groups? Because there is a bigger cause of morbidity and mortality, indirect cause of mortality, of course. So that is one question. And two is, randomized control trials is, of course, an age-old method for drugs. We do randomized double-blind control trials for drug testing. Now, I've been reading a lot about these since I come from a technology background. When you actually want to study the amount of change attributable to an intervention, in when you're randomizing patients, in treatment and control group, you have ways of estimating a proper sample size you need, adjusting the confounding to find out the amount of change. Now that is really a problem when you randomize groups and communities. So what I fear is at times there could be a chance that we may, merely by adjusting the confoundings between two groups, we conclude that this change is really due to our intervention. But ruling out the possibility of chance is really difficult when we randomize groups vis-a-vis individuals into treatment and control groups.
Yeah, as far as the preschool age group is concerned, I'm not aware if there's any data availability on that. But certainly in the school age, we saw the kind of impact. In a routine way, if it is going on in the department, I'm not aware of right here. But we felt that it is the school age where they are the most productive age group, and if that age there is more absenteeism and then they are going back on the literacy levels, that's more costlier kind of a mistake to the economy and the society at large. So that's how we thought about the preschool, and then it's much easier to implement it with the school environment. So that's how we went about.
I mean, there's a lot of stuff in what you said, so I'll be brief and we can take this offline. First, glad to know about the worm load assessment, Leslie, so that's something you can coordinate. I think on the comments in the previous session on supply versus demand, I mean, I think clearly, it's not one versus, if both will have a bigger impact. But I think the main contribution of that lentil study, right, is to kind of showcase showcase attention on a very simple fact, which is if you were to assume that the lifetime benefits of immunization are pretty substantial, that it's not rational to think about why this little bag of lentils is making such a big difference. And I think the point there is bringing in psychology into the way we design programs, and the behavioral economics research shows that people severely overestimate or kind of overweight short-term costs and underweight long-term benefits. And so if in addition to the supply, if the person who's in the village with the shots is also sitting with a bag of dal, and if you're able to get a force multiplier, if with supply you're getting up to 50%, why not also go and do that? And I think the point is just to showcase that a very low cost, simple intervention has such a substantial impact. On the last point about the statistical validity of the clinical trials when you do group randomization, I mean, there are very well-developed statistical protocols for cluster randomization, which includes estimating intra-cluster correlations and figuring out the power and the sample size needed, and we do that for pretty much everything we do, so we can talk more about that.
So Leslie could probably answer this better than I can. But on the preschool point, I mean, it is true that the health impact on preschool children is higher than on school age children. However, A, it's hard to get to every preschool trial, and B, it's actually the school age children who have a very important role in transmitting the disease across the community. So what we find in Kenya is you mass treat the school children because they're easy to get to. And that breaks the transmission of the disease, because they're the ones running around. To put it crudely, they're the ones who are running around and they're not using the correct sanitation. Whereas the preschool children tend to be in a relatively small, constrained area. So the school-age children are giving it to the preschool. So if you can treat them, you actually see a lower disease rate amongst the preschool. And it's easy and cheap to get to the school-age children. And that